Thank you for the opportunity to present our work. Here are our disclosures. Patients who report urinary urgency, frequency, nocturia, and urgency urinary incontinence are often managed with multiple treatments. As we all know, treatment adherence significantly impacts a patient's clinical response to treatment, and there are data that suggests that discontinuation rates of medications for overactive bladder near 50% by the first month of treatment. To date, limited data exists describing changes in treatment over time and factors that are associated with changes in treatment. Thus, the primary objective of our study was to describe the real-world treatment patterns over 1 year for women presenting to specialty care with urinary urgency and/or urgency urinary incontinence. This was a secondary analysis of data from the Symptoms of Lower Urinary Tract Dysfunction Research Network, otherwise known as LURN. LURN is a multi-center, 1-year prospective observational cohort study that enrolled adult patients seeking specialty care for lower urinary tract symptoms. For this study, we included female participants who reported bothersome urinary urgency, UU, and/or urgency urinary incontinence, UUI, of sometimes or greater on the LUTS tool. Data regarding treatment for UU or UUI were collected and analyzed, and treatment groups were ordered from least to most invasive, with the lowest level being 0, no treatment, and the highest level being 6, sacral neuromodulation. We then quantified treatment changes during the 12-month study period and categorized the treatment changes as an escalation, that is an increase in treatment level, a de-escalation, that is a decrease in treatment level or no change. Participants were queried at baseline and at each of 4 follow-up visits regarding any previous and current UU or UUI treatments over 12 months. Treatment escalation and de-escalation and types of treatment were explored graphically in 2 ways. The baseline characteristics of the cohort are shown here. 349 women met inclusion criteria, 281 reporting bothersome UUI, and 68 reporting bothersome UU only. The mean age was 57 years, and most participants identified as white. Nearly half had a psychiatric diagnosis, and a similar number of participants had hypertension. Regarding LUTS treatment prior to or at baseline, 2/3 of the cohort reported behavioral therapy and 13% reported PT. At baseline, 10% were taking OAB medications, and a few participants had undergone PTNS, Botox, or SNM. 10% had undergone a sling prior to enrolling in the LURN study. This table demonstrates the differences in patient-reported outcomes in the participants at baseline. The mean overall LUTS tool severity score was 47.7 and was higher in the UUI cohort compared with the UU only cohort. UUI participants had more severe frequency, urgency, and incontinence symptoms than UU only participants. The PROMIS measures were all within 1/2 standard deviation of the normative population mean, except for PROMIS physical function, for which the UUI participants had lower physical function than the normative population mean. This figure is a Lasagna plot that shows the patterns of the highest level of treatment during the study period. At baseline, 52% reported behavioral therapy, 11% PT, and 10% OAB medication, while 26% did not receive any treatments of interest. The majority of participants who did not receive any of the treatments of interest were treated during the study follow-up, with approximately equal number undergoing behavioral therapy, PT, or overactive bladder medication. Among those using behavioral therapy at baseline, 25% discontinued behavioral therapy and remained untreated during the follow-up. 32% discontinued behavioral therapy, while 19% were escalated to PT and 20% to OAB medication. Among those on PT at baseline, 26% discontinued PT and did not receive any other treatment during the study follow-up. 8% de-escalated to behavioral therapy, 47% continued physical therapy, and 8% escalated to an OAB medication during the study follow-up. Among those on OAB medication at baseline, 80% continued use and 20% were escalated to a 3rd-line treatment. Third-line treatments were the least commonly used mode of treatment, with only 3% of participants using Botox, 1% PTNS, and 3% SNM prior to baseline or during the study. This figure represents the patterns of treatment escalation and de-escalation during the study period. The most prevalent treatment escalation from baseline to 3 months was a change from behavioral therapy to medication, while the most prevalent treatment de-escalation was behavioral therapy to no treatment. From baseline to 12 months, 14% of participants reported no change in level of treatment, 63% reported any escalation, and 68% reported any de-escalation. To summarize, nearly half of the participants presenting to specialty care clinics with UU and/or UUI reported conservative measures only during the 12-month study period, despite reporting bother from these symptoms. Participants who were either on OAB medications at baseline or were started after their first visit tended to stay at this level of treatment, and very few participants were escalated to third-line treatments. Treatment patterns for UU and UUI are diverse, and even in specialty centers, treatment for U and UUI most often involve no treatment or only conservative therapies. Thank you.